Hi, I'm Jack Cush, Executive Editor of RheumNow.com. Today is the 14th of October 2016, and this is the RheumNow Week in Review. I'm coming to you this week from the Emirates Rheumatology Society meeting here in Dubai, the ESR meeting, where I'll be lecturing. But I wanted to review this week's news and journal articles of importance from the website, so here we go. The prevalence of uveitis in the United States, as you know, adalimumab received recent approval for use in non-infectious uveitis. The scope of the problem, we certainly know that our patients with spondyloarthritis, up to 20% of such patients will have a risk of uveitis, including acute anterior uveitis. But the overall risk of non-infectious uveitis, based on a claims data study recently published in JAMA Ophthalmology, showed that there's 300,000 adults in the United States and almost 22,000 children who have non-infectious uveitis, an important number for those who treat patients and those who are involved in public policy for such patients. Talking about numbers, the size of the biosimilar market is about to change with the introduction of 3 new drugs. In 2015, global sales of biosimilars was $3.5 billion. It is expected that by 2022, 7 years from now, that will grow almost fivefold to $15.6 billion, and those are just estimates. We certainly know from a recent study that looked at very high levels of CRP and SED rate in a rheumatology population that you should worry about patients who have high CRP levels, especially more so than ESR, and yet don't have findings that are supportive of a rheumatic diagnosis. That, again, very high CRP levels with non-specific findings should always raise the suspicion of a non-rheumatic cause, such as infection or malignancy. Another thing you should know, of course, is that patients with rheumatic diseases do top the list, being the most common cause of extreme elevations of SED rate and CRP, accounting for 52% of such cases. And within that group, the most common diagnoses included PMR and seronegative RA being over 30%, infection being 25% of the causes, neoplasia 9% of the causes. Medicare study, a very important study from a Medicare analysis, showed that women who have a history of breast cancer, who go on to receive subsequent anti-rheumatic therapy, are at no higher risk for breast cancer recurrence if they go on to receive either methotrexate or a thiopurine or a TNF inhibitor. Again, this is a study of women with breast cancer who had a diagnosis of IBD or rheumatoid arthritis. And again, TNF inhibitors in this case, again, did not increase the recurrence rate in women with breast cancer. An important point that I keep making, that you treat the arthritis, let someone else treat the cancer or worry about the cancer. A study from Norway looked at the risk of fracture in psoriasis. This has come up a few times, that some people feel that there is a risk of fracture in those who have psoriasis, but the data from this very large Hunt study showed that there was no increased risk of fracture amongst those who had just psoriasis only. A review of diabetes patients and the articular and periarticular findings associated with that showed that the most common articular manifestation was actually osteoarthritis of the knee, accounting for half the cases. Other common causes, other common etiologies underlying articular complaints in diabetics included carpal tunnel syndrome in 29%, frozen shoulder in 23%, and 16% who have diabetic chiroarthropathy. A meta-analysis looked at what happens when you have either an arthrodesis of the ankle versus an ankle replacement. And it looked like that the outcomes as far as function and pain were basically the same. However, if you had a total ankle arthroplasty and replacement, reoperations and complications were much more common with the ankle replacement surgery. A phase 2 study that looked at abatacept in multiple sclerosis, this was called the ACCLAIM study, actually failed to show any benefit of abatacept in patients with multiple sclerosis. Good news in the scleroderma world, where there's not enough therapies being developed. There's an endocannabinoid therapy called RheumNow JBT-101. It's now entering clinical trials. It's thought that this drug, at least in animal models, decreases TGF-beta and collagen synthesis. What it will do in scleroderma patients remains to be seen from this clinical trial. A study coming from Eric Madison's group at the Mayo Clinic showed that in those who have recent onset or incident sarcoidosis, they actually have a 3-fold higher risk of venous thrombosis and a full 4-fold higher risk of pulmonary embolism. I did not know of this risk of thromboembolic disease associated with sarcoidosis, something to take note of. Original journal articles, a nice blog and article written by Sergio Schwartzman looked at his take on the new ophthalmology AAO guidelines on how to screen for hydroxychloroquine. As you know, they recommend that if you have no risk factors, that you have a baseline exam and that you really don't need to have a second exam until 5 years later. And then after that, it should be every year. Those who require more frequent testing, annual testing like we were currently doing, are those who are at risk, diabetics, people who have retinal or macular disease, and those with renal insufficiency. But again, there's some concern because this data and these guidelines were generated based on one study that Sergio reviews, a JAMA study that showed some of these numbers. Whether or not this is something we should be adopting remains open to discussion. Analysis of a small cohort of patients who are first-degree relatives of spondyloarthritis patients, in fact 51 patients, showed that 1/3 of these individuals, 17 out of 51, developed spondyloarthritis based on ASAS criteria when they were just a first-degree relative of patients with AS. Previously, we knew that patients who had that profile, being a first-degree relative of someone with AS, supposedly carried a 20% risk, especially if you were B27 positive. This new data, although based on fewer patients, suggests that it could be somewhat higher and maybe as high as 33%. Newly released guidelines, or not guidelines, but criteria for the diagnosis of the cryopyrinopathies or CAPS patients. This is a rare syndrome, mainly affects children, can affect adults with Muckle-Wells syndrome, and also includes familial cold or inflammatory syndrome, and Muckle-Wells, as was said, and the NOMID or SINCA syndrome. The criteria used for this diagnosis requires 1, a high acute phase reactant like CRP or serum amyloid A, and then at least two out of the following 6 that would include urticaria, onset with cold exposure, the presence of sensory neural hearing loss, musculoskeletal symptoms, aseptic meningitis, and skeletal abnormalities that show up on X-ray or imaging or with deformities. So those criteria developed by experts will be useful in patients who diagnose these people or those who do clinical trials in this area. Lastly, a nice review of aromatase inhibitor arthralgias has come out, and I also threw in some extra information. As you know, women who have breast cancer that is estrogen receptor positive may need to go on long-term aromatase inhibitor therapy, and unfortunately, up to 50% of patients will have musculoskeletal symptoms in association with aromatase inhibitor therapy. It can be arthralgias, myalgias, frank arthritis, and a myriad of different autoimmune kind of features. The etiology of this is really not known. Some think it may be due to a deficiency of vitamin D, but it's not quite that simple. In this particular follow-up, they found that in a review of 21 patients from their site who had arthralgias, arthritis, and SICA syndrome, that when they looked at the 17 who were available, the majority of them had cessation of their symptoms upon stopping the drug. Usually 70 or 80% responded within 3 months of cessation of drug. Most patients got better or stopped their symptoms. 4 out of the 17 continued on with chronic arthritis, synovitis, or SICA symptoms, suggesting in some people it may actually bring on the onset of a musculoskeletal or autoimmune problem. So that's it for this week at RheumNow. If you want the information about these particular citations, you can go to the article and the video We've got the links up there that you can go and find more information about that. Be sure to download this on iTunes. You can listen to it while you're exercising or driving to work. Be sure to register on the website. You'd be doing me a big favor if you can go to the website and register in the right-hand corner. Registration allows you to get involved in commentary, to download articles, and to also customize the way you want information delivered to you. For instance, you can get not only a weekly email instead of a daily email, but you can get a topic report sent to you every week or every month. Let's say you're a lupus person or a psoriatic arthritis person, we'll send you a monthly report with just those topics in the email. And lastly, if you haven't thought about it, think about attending the RWCS meeting coming up in February. That's r-w-c-s.com. That's a meeting run by Artie Kavanaugh in Maui. I'm part of the faculty. It's a great meeting. If you register now, you can get a Friends of the Faculty discount. That's it. We'll see you next week. Enjoy.